So Sir, we are live. Good to go.
Hello, and a very good evening to all the delegates and faculty members. I am Dr. Dhammadip Dabade, and on behalf of Emcure Pharmaceuticals Limited, I welcome you all on the occasion of No Thrombosis Live in Box. No Thrombosis Live in Box is the scientific initiative by Emcure wherein we learn and understand about various cardiac interventional case scenarios with the help of live case recorded case series by the expert cardiologist and which are deliberated and discussed by the expert moderators. So for that, we have with us today, it's my privilege and honor to welcome our moderator, Dr. D. Ramesh sir, for this webinar. Sir is the professor and HOD of cardiology at Vedehi Institute of Medical Sciences and Research Center, Bangalore. Sir being the professor of cardiology and in charge ESI MH SJIC unit, honorary treasurer and secretary and the governing council member for Indian College of Cardiology, governing council member for CSI Bangalore chapter, international member European Society of Cardiology, organizing committee member of CSI Bangalore 2004, organizing committee member of Conference of Indian Echocardiography Society 2006, faculty at various national and international cardiology conferences, and multiple publications in his credit at reputed journals. Thank you, sir, for joining with us for this webinar. It's my privilege and honor to welcome and introduce our moderator, Dr. Raju Garg, sir. Sir is the senior consultant interventional cardiologist from Aware Glengales Global Hospital, Hyderabad. Sir associated with Heart Failure Clinics and Cardiac Transplant Program, life member for API CSI Indian College of Intervention Cardiology, life member for Indian Society of Echocardiography, Asia Pacific Society of Intervention Cardiology. Sir presented over 6 papers in national conferences, visiting faculty to TCTAP, Seoul, South Korea, and associated with various clinical trials, FAMI, Rivera, Sepia, Shine, etc. Welcome to you, sir, and thank you for joining with us. It's my privilege to welcome and introduce our speaker, Dr. R. Sasinthar, sir, consultant cardiologist, currently affiliated with the Vadamalayan Hospital, Madurai. He will be presenting a case, ultra low contrast multivessel PCI using saline OCT guidance. Welcome, sir. It's my privilege and welcome and introduce our second speaker, Dr. Pranav B. Shamraj, Chief Cardiologist from BKL Valvalkar Rural Medical College, Chiplun, Ratnagiri, Director Cath Lab at Bajaj Finserv Comprehensive Cardiac Center, BKLWH. Sir will be presenting case on stent deformation during PCI. Agenda for today, we'll be having the opening remarks by our both the moderators, followed by the case presentation by Dr. R. Sasinthar, sir, and the discussion amongst the moderators. We'll be also taking the questions from the audience after this case presentation. We'll be having second case presentation by Dr. Pranav Shamraj, sir, and followed by the discussion amongst both the moderators, followed by the concluding remarks and the vote of thanks. So once again, I welcome to all the delegates and the faculty members, and a humble request to all the audience for putting your questions followed by each case presentation so that we will take it for the subsequent discussion. So with that note, I would like to stop here and we'll hand it over to our moderators. So first, Ramesh sir and then Raju sir. Thank you.
Good evening, everybody. And good evening to our, all the faculty members and especially Raju Garg. So at the outset, I would like to thank the Emcure pharmaceutical company and the organizers of No Thrombosis for giving me an opportunity to be the part of this great academic initiative. And anybody who is associated with this initiative would be very happy to be back onto this screen, because we learn a lot from this particular program. The idea of conducting such program is we would like to see the interventional cardiologists, how they plan out their line of action, taking into consideration the clinical outcomes and the comorbidities, and how they execute the plan, keeping safety in consideration, and achieve the clinical outcome with good result, so that the others can learn from their technique and cutting edge knowledge. So with these few brief remarks, I would like to pass on the mic to Dr. Rajiv Garak for his comments.
Yeah. So thank you, Dr. Ramesh. Welcome, Dr. Shashintran and Pranav. And it's a very important thing which Emcure has taken in a long way. I think it's a very good initiative. And I get reminded of seeing Dr. Shamim Sharma's case on every Tuesday, every month. So a nice initiative from Emcure. It will help all the people seeing the discussion, and it will make us visit this conference again and again and learn a lot of things. Always the topics are new and the discussions are of high academic content. So let us hope we carry on this mantle again and again through various moderators and speakers. And we should thank Emcure for an unrestricted grant they provide for this type of activity without any commercial tag on it. Thank you so much.
Sir, with your permission, sir, Rajiv Garak, shall we start the case? Shall we start the first case?
Definitely, sir.
Can I call upon Dr. Shashintran to present ultra low contrast multivessel PCI using saline OCT guidance?
Good evening, one and all. Yes, sir. Yes.
Over to Shashintran.
Good evening, one and all. Good evening, dear moderator and chairperson, and good evening, one and all. So I'm going to present a case we did with ultra low contrast PCI using saline OCT guidance. It's a multi-vessel PCI. So our center, we are in the beginning stages of doing ultra low contrast, or other words, zero contrast PCI. But we have quite a few experience with saline OCT guidance. So on introduction, contrast-induced acute kidney injury is a serious issue which has to be considered following especially percutaneous coronary intervention in patients with CKD, as it prolongs the duration of hospitalization and increases financial burden. It can lead to mortality outcomes as well. So the solution to only two solutions. One thing is reducing the contrast agent. Second thing is prehydration. These are the only two solutions to prevent contrast-induced AKI. What is the definition for ultra-low contrast PCI is ideally the ratio between the contrast volume used and the eGFR patient to be kept less than 1, then you can call it as ultra-low contrast PCI. For example, if the patient has a GFR of 60 ml, then if you keep the contrast volume below 60, that would be enough. That we can call it as ultra-low contrast PCI, because if you keep this ratio below less than 1, the chances of developing contrast-induced nephropathy is extremely rare. So our case is a 57-year-old gentleman who is a known diabetic for 7 years with a poor diabetic control of HbA1c 9.1 and a known hypertensive as well, presented with acute onset angina of 6 hours duration. This patient also gave a history of acute kidney injury some 2 years back when he presented with UTA. So this was the ECG on presentation. As you can see, the patient is having sinus tachycardia with ST elevation in leads 2, 3, and AVF, with reciprocal changes visualized in the precordial leads. As you can see, if you try to localize the culprit artery, you can see the ST elevation in lead 2 is more than 3, and lead 1 and AVL not showing ST depression. Instead, lead 1 is showing ST elevation, and there is ST depression in V2, which points to more towards LCX being the culprit artery. So this is a ECG post thrombolysis with retiplase. The patient developed accelerated idioventricular rhythm, and during the sinus rhythm, you can observe that the ST elevation has decreased compared to the previous leads. The subsequent ECG which was taken showed significant reduction in the ST elevation, and the patient's chest pain settled immediately. Reciprocal changes also settled significantly. This patient's troponin was elevated, and serial troponins had shown significant elevation. The presenting creatinine of this patient was 1.7, even though we cannot calculate eGFR at this stage because some kind of acute kidney injury might also be there during the myocardial infarction stage. The GFR calculated was 41.8 ml, and his ultrasound abdomen revealed increased renal cortical echoes but normal sized kidneys. So he had an adequate LV systolic function with RWMA pointing towards L6 territory. So we did coronary angiogram within 24 hours as per the guidelines. So this is a coronary angiogram done via radial approach. You can see the left main is short. This is in the apicaudal view. And you can see in the LCX is dominant, and the obtuse marginal has an ostial 60 to 70% lesion, which is extending till this small branch. The LAD appears to have minor plaque in the proximal region. And this is the epicranial view. You can see there is significant lesion in the mid-LAD lesion along with calcification astride the diagonal branch. This is the RAO cranial view. You can see the same lesion, diffuse calcific lesion in the LAD extending from the mid-LAD along astride the diagonal branch. So we used 12 ml of contrast for coronary angiogram. And since this patient is medically stable, so we waited for the creatinine to improve, and we medically managed the patient and planned for elective PCA of the culprit artery, which we regarded OM as a culprit artery, and PCA of LAD as well. So by now, after 4 days, eGFR has improved slightly, and we planned for PCA using OCT guidance in order to reduce the contrast overload, which is because the patient had previous history of AKA and ultrasound abdomen showing kidney damage. So this patient we took via radial approach. We used a 6 French extra backup catheter as 3.5 as a guiding support. And using the previous CAG as the landmark, we introduced the guide wire using a blind walking stick approach into the obtuse marginal branch. So as you can see, the guide wire passing into the obtuse marginal branch. And we did what is called as a saline OCT. So usually we do saline OCT after putting a guideliner. And in this case, what I did is, since the left main was short, I deep cannulated the EBU guide into the LCX and did saline OCT. So before doing saline OCT, I put another wire in the small side branch in the OM branch. This I used as a metallic silhouette before marking the using OCT. As you can see the OCT lens moving here, imaging the culprit lesion. So this is the OCT image of the obtuse marginal. We can see there is reasonably good image obtained, good blood clearance even with saline, and because of the deep cannulation. So this is the distal part of the OM. You can see the vessel is lumen to lumen 2.75 millimeter and EL to EL 3 to 3.25 millimeters. And this is the distal reference where the lumen diameter is a healthy segment in the distal part of the lesion. As you can see, a fibrous plaque started appearing in the OM, which is predominantly 360 degree. You can see lipid burden is also there. And this is a small side branch which is joining the OM. You can see the second guide wire entering. And this is just after the side branch has joined the vessel. And this I measured for determining what is the size of the pod balloon I should use. So EL to EL at this point in the OM is 3.5 millimeters. And you can see a significant macrophage infiltration in the vessel along the fibroathyroma. You can see the two guide wires in the OM. As you ascend up, you can see the lesion getting severe and severe. And here you can see a 360 degree fibroathyroma with some kind of erosion. And at this point, there is ruptured plaque. There is significant ruptured plaque. You can see in the 7 o'clock position. As you ascend further up, this is the ostial part of the OM. The ostial part, you can see there is another ruptured plaque here. There are 2 ruptured plaques here in the same vessel. There is not much of calcium except for some islands of calcium here and there. There's not much of calcium. Significant fibroathyroma, circumferential till the ostium of the OM, and some degree of athyroma in the LCX as well. And this is the LCX part that is less plaque burden compared to the culprit lesion. So this lesion, definitely the minimal lumen area was less than 1.9. It was actually measured to be 1.6 millimeter. So we plan to intervene this lesion. So based on the OCT findings, we decided the landing zone. We prepared the bed with the 3 mm NC balloon at 8 atmospheres. And we positioned the stent. So this point, what I thought is I could pull back this wire and put it into the LCX and do the ostial stenting here. But what I realized is ostial stenting is a little bit difficult to do with zero contrast. So we used a minimal diluted contrast, about 3 ml, and determined the exact ostial position and deployed the stent. So our idea is to deploy at the ostium, and even if it goes into the L6, we are not, it won't be a problem because we will be able to expand the stent to the L6 because the lumen to lumen was around 3.6 millimeters. So we deployed a Zions Alpine 3x33 at 14 atmosphere, and we did a pot with a 3.5 into 12 millimeter non-compliant balloon at 16 atmospheres. So this is the final OCT. The final OCT we had to do with the guide extension catheter, that is a telescope catheter, because we could not pass the OCT catheter per se. So we used a guide extension catheter, 2 purposes: for introducing the catheter and for obtaining a proper saline OCT image. So this is the saline OCT image post stenting of the OM, obtuse margin image. You can see the distal part of the vessel, the stent has landed perfectly without any dissection, and fully the stent is apposed properly, except for some blood clearance is not proper in certain parts within the stents. Everything, other things appear to be normal. The MLA increased to more than 6 in most of the part of the stents, and expansion was also adequate. So what I found is there is a little bit of longitudinal stent elongation, and the stent has landed in the L6 also, but the apposition was good. And we are happy with the result. So L6, we know that it's going to be a, if not, there won't be much of a complication except for slow flow. Since the patient did not show any signs, we didn't take any angiogram at that point. This is a coronary angiogram image for LAD. So before doing an ultra low contrast PCA, we obtain the anatomic landmarks from the angiogram itself. For in LAD, if you take, there is significant calcific calcium seen here. We took all this calcium as landmark. We can see there is significant calcium here, just above the diagonal. This may be a provisional proximal landing zone. Here also there is a calcium seen. So this is the top end of the calcium, and significant calcium is observed where the diagonal origin is seen. And even at the diagonal origin also, even if you don't see a calcium in the still image, if you see in the moving image, you can see there is calcium in the diagonal ostium as well. So that we can use as a landmark. Even without the wire, this case we can proceed because we have calcium at the diagonal ostium, which will serve as a landmark for low contrast PCA. So LAD, we had the guide extension in place, and we initially prepared with a 2 mm semi-compliant balloon for allowing the OCT catheter to pass through. And we did the first OCT, pre-OCT for LAD. And as you can see, the contrast clearance was not that much great, but good enough to give adequate all the information. This is the distal landing zone, the length of about 2.8, which is EL to EL. And the lumen to lumen is maximum 2.3. There are multiple fold over and stitch artifacts as well. You can see again there is fibroathyroma in the mid LAD. And as we ascend to the proximal LAD, this is 360-degree fibroathyroma, which becomes more severe. Here, there is significant blood here. And this point, it's a very tight stenosis. And there is significant amount of calcium occupying almost 180-degree here, with the width of the calcium more than 500 microns, which measured here to be 800 microns here. As you can see, the width of the calcium is 800 microns. So this patient will definitely require calcium handling strategies. We had a scoring balloon at the lab, so we went ahead with bed preparation with a scoring balloon. So this is the proximal mid LAD, just before the diagonal branch. And this we decided to be the proximal landing zone. So the maximum lumen to lumen is around 3.8. So using the guide extension, we introduced the scoring balloon, 2.75 into 10 mm scoring balloon, and went up till 16 atmospheres. After the scoring balloon, we prepared with the 3 mm NC before the diagonal branch, and we deployed the stent, which is 2.75 based on the distal landing zone. We took a 2.75 into 33 alpine stent, and we used the calcium as the landmark. So using the OCT, we determined that where to land distally just after the diagonal branch, and proximally using the OCT just at the top of calcium we have to land. That is a proximal landing zone. And this is the diagonal origin. See, this is the diagonal origin, and this is the top of calcium at which the proximal landing zone we determined using the OCT. So after stenting, we observed under expansion as well. We initially did the pot with the 3.5 into 15 millimeter NC non-compliant balloon, and then went ahead with post dilatation of the stent using 3 into 15 mm NC, and at the calcium at 22 atmospheres. Until then, the patient was doing well without any symptoms, and there was no ECG changes. At this point, the patient started having chest pain, and ECG ST depression also started appearing. So at this point, we decided to give some contrast. So here, as you can see, the patient has developed no flow at this point. So there are several causes of no flow. Most important two causes being dissection, distal dissection and closure of the vessel. Second important cause is embolization of the lipid segment, causing distal embolization and no flow. So we carefully introduced a balloon. We used a perforated balloon catheter, and we found out that the contrast was going well. So we delivered vasodilators at the distal LAD using a perforated balloon. And we waited for 5 minutes. Slowly, the chest pain started disappearing, and ST changes also started disappearing. So at this point, so we did the final check angiogram, which showed TIMI3 flow and reasonably expanded stent in the LAD. So unfortunately, due to some technical reason, I could not do the final OCT pullback because I could not introduce the catheter inside due to the wire bias. You can see the stent implanted in the LAD, and this is the AP caudal view showing the stent implanted in the obtuse margin. So the total volume of the contrast agent used initially before the no flow was less than 10 ml, but after the no flow, we had to utilize another 15 ml of contrast. So the total contrast used was 24 ml, which was still less than, significantly less than the ratio less than 1. And fluoroscopic time, we 31 minutes, and procedure time 1 hour and 15 minutes. And follow-up also, patient did not show any evidence of contrast-induced AKI, with the creatinine level of 1.3 and EGFR of 56.9. So with this, I stop my presentation. If time permits, I will discuss the tips and tricks for performing low contrast PCA.
Dr. Rajiv?
Yeah.
Dr. Rajiv Garak, go ahead.
Yeah. So Good case, doctor. And I think a lot of learning points from this. The most important, as you told, all our viewers should know what is the definition of what you say ultra low contrast PCI. And you very well have told the definition is contrast volume by EGFR should be less than 1. So basically, ultra low contrast people should not go with the idea that no contrast is being used. But it is a very low contrast amount, which will permit us to avoid the complications of CKD. Now, doctor, only one, you have completed the procedure with 24 ml of contrast. That is very nice. But in the LAD and LCX, both, you have converted a bifurcation lesion practically into a simple PCI and yet excellent result. So what is your second thought if by chance you would have performed a bifurcation LAD D1 lesion, D2 rather, it was D2.
Yes, sir.
What was the estimated risks you would have handled? Though the D2 looked less than 2 millimeters, but if it were more than 2, then what are the options you would give, thought about during the PCI?
Yes, sir. Before the PCI, yes, sir. Yes, sir. A side branch occlusion was also a significant thing, but here, and both angiogram wise and with the OCT also, the side branch high risk features of side branch occlusion was not seen. So except for opposite wall calcium, sir, I found opposite wall calcium to be very significant thing which can lead to side branch occlusion. Apart from that, there was not significant much of.
Yes, and then the use of rotablation versus
yes, sir. And the result score was also very low, so we went ahead with provisional stenting itself. So I didn't wire the diagonal also because of the same reasons.
Yeah. You maintained it and made it simple and yet successful. Now, regarding choice of handling the calcium, we can always debate whether we should have used rotablation versus the cutting balloon. So what are your thoughts? Why did you choose cutting balloon over rotablation in this case?
So first of all, this patient, we don't have a standby rota in our center. So that is one reason.
Assume you will have a rota, then what would have you done?
So this patient, there is not a 360-degree calcium, sir.
But it was almost 260. It was more than 180 degrees. So any lesion more than 180 arc of calcium over a period of long distance, how do you, I want for the audience, basically, you have done a good thing. How do you choose between a cutting balloon versus rota? What are the points?
Sir, first thing is if the lesion is more than 180, calcium is more than 180 degree, and the calcium depth is more than 500 microns, and the length is more than 5 millimeters, definitely calcium needs calcium handling strategies, of which cutting balloon, scoring balloon, rotablation, all are options. My hunch is that if you have a 360-degree calcium and balloon fails to cross, so definitely we'll have difficulty in passing the cutting balloon, rotablation. Definitely without rotablation we will not be able to proceed, sir. So here we got away with cutting balloon, and post cutting balloon 3 mm NC was expanding well, so we thought of going with stenting.
And what would be your opinion on IVL, latest in the armamentarium, in these calcified lesions? How would you place the IVL usage in this case, if finance is not a limitation?
Yes, sir. If the calcium is not superficial and is very deep, and definitely IVL would be a very good add-on for breaking the calcium as well.
Yes.
Softening the lesion and giving good stent expansion as well.
Yes. And for your ostial LCX, you preferred alpine. What would be your opinion about onyx as a stent over alpine in ostial situation?
Sir, onyx, what I found, my experience, yes, sir. Radial, the trackability of onyx is slightly better than alpine, sir. So that would be an advantage if we have any angulated lesions. I would have preferred onyx. Apart from that, do you have any points to add, sir? In the ostium lesion, is there any difference between these two stents?
The stent deformation is less with the onyx.
Yes. Okay, so fine.
Because it's
Basically,
not
the
a tube.
stent deformation, yes. What is the point to I wanted to drive in is that only. And then while doing low contrast PCIs, you have very well used the calcified spots as your landmarks, which is the take home. All of you should have a proper, what you say, procedure angio, and rightly said, you should stage your procedure for 3 to 7 days to avoid what you say injury to the kidney. And most important is the views and the landmark, how you park your guide wire and the balloon. Very important, because we are depending totally on landmarks to have proper placement of stand from healthy to healthy segment. Dr. Amish, what you would say on that?
Yes, sir. Sir, I would like to ask you a question. Why did you use IVUS instead of this one strategy? Because IVUS is would have been a better strategy.
Yes, sir. IVUS definitely would have been better. If you plan to perform a low contrast PC, IVUS will be a definitely better option. But we don't have a standby IVUS in our centers. We have only OCT as an imaging in our center. And we have done previously a lot of cases with saline OCT, and we were confident enough that we could finish off this case without using much of contrast.
When you are doing this OCT with clear saline, was it a pressure injection or with hand injection?
So we use 20 ml syringe, sir. 20 ml syringe with a hand injection.
No, normally they say we use a pressure injection at the rate of 5 ml per second, 20 ml, so that the clearance would be about 3 to 4 seconds or 3 to 4 minutes, so that there's no ischemia. It gives a better
Yes.
delineation. What do you say for that?
Sir,
Yes.
sir, hand injection, if we are confident enough, we have tried.
It again depends upon the operator, you know.
Yes. Main difference is the consistency will not be seen with hand. Just a few microseconds later, the clearance will be bad, and at one part of the vessel, the clearance will not be seen. That is the only drawback with hand injection. But pressure injector, definitely, yeah.
I would like to know, why did you do pot when you're doing, it's not a bifurcation stenting. You did a pot after putting a stent across the
Sir, OCT wise, what I observed, yes, sir. In obtuse marginal, OCT wise, I observed.
I'll tell you why there was slow flow, because you did a pot and overexpanded the lesion, the debris which were there, God, the sludge started moving downstream. So that caused a no flow phenomenon, because there was no need to do a pot, you know. No, that is my feeling. Any reason why you did pot? Normally we do pot when you do a bifurcation stenting, just to see that the side ostium is open. Yep.
Yes, sir. Yes, sir. My understanding is LAD is a tapering vessel, and especially after a side branch, the size of the LAD varies significantly. And even if you do a provisional stenting across such a side branch, I feel the proximal pot is necessary for two reasons, sir. One reason is to keep the side branch open. Second reason is that stent struts will conform so that the side branch struts will be minimized. The amount of side branch struts will be minimized in the diagonal ostium if we finish off with the pot. Second thing is, if there is doing a pot, introducing, if the wire thing is lost, and reintroducing the wire may go under the stent struts, which we do not want it to happen. Yes, sir.
Did you use stent boost or any other technique to visualize the proper expansion of stent?
Sir, since we routinely use stent whiz, sir, in our cath lab, but since we did the OCT in this case for OM, we didn't do a stent whiz. For LAD, we did a stent whiz, sir.
Fine. And as sir was saying, basically, yeah, because of pot, probably microembolization of the calcified particles was there, and so you got a no reflow. But otherwise, it's a very well done case. And OCT over IVUS in osteal lesions, I think IVUS is better. And in an acute MI situation, OCT is better because thrombotic lesions are there. But still for ostial lesion, IVUS is preferred because it gives a better visualization.
Yes.
Dr. Ramesh, what is your opinion on that?
Yeah, you're right. Absolutely right, sir. Absolutely right. Since there
But
are
all technologies are cost dependent and availability dependent and
operator
anyway,
dependent, sir.
yeah, operator dependent. And actually, in the evolving world of intervention cardiology, where cost constraints are there in many institutions, always we leave it to the operator, and discussion is for more of theory. But with OCT also, you get equally good results. There's no problem. So, congratulations, doctor.
Yes.
And I think we can move to the next case.
Sir, before we move to the special, let me
Yeah,
share.
you can show some tips and tricks, no problem.
Hey,
Give you five
so that there,
minutes for it.
so
I
can
will
you
stop sharing.
Yeah.
Yes, sir. Yes, sir.
Because there are few junior colleagues who would like to know why these things happen. What are these?
Yeah, I think you allow question answer. Okay.
Yeah. Okay.
So let us go to the chat box.
No. Yeah, I'll just present one. This one about this low contrast angio.
Sure. Definitely, sir.
So all of us must be, by this time, we should know that whether it is a MI or a acute coronary syndrome, well, be it ST elevation or RST elevation, the incidence of CKD varies from 14 to 32%. But when you're intervening in a patient with acute coronary syndrome, the incidence of CKD can be varies from 25 to 50%. In other words, the CKD and ST ACS are two sides of the same coin. So one should be aware of that. And the contrast, what doctor was alluding to was, if the contrast volume divided by EGFR is less than 1, then the contrast-induced nephropathy is less. But when it exceeds 1, then the contrast-induced nephropathy increases by 4 to 5 folds. Therefore, it's absolutely essential to keep the contrast volume, the ratio of contrast volume by EGFR less than 1. And secondly, you have to pre-hydrate depending upon the LVDP, not blindly 50, 60, 70 as per the whims and fancy of the operator. It should be as per the LVDP. And whenever you're doing projection to reduce the contrast volume, if you're doing RCA, it should be LO cranial, which is fixed, or if it is LCA, it should be AP cranial or AP caudal. Now, these are the steps. It's for the junior colleagues, and it is not for Dr. Raju Garu. So it's so when you do the steps is before do PCI, so you do pre-specification, and the stage PCI should be done after a week or so. Then once you store and recall the acquired image, then you use coronary artery imaging, which is various steps. Most of us use optic cross, and if you are using OCT is Dragonfly. So why we do the coronary imaging? We have to know the underlying pathology, and if it is a calcium, we like to know whether superficial, deep, or nodular. Now, based on that, we can select the plaque modification device. Based on that, once you do the thorough preparation of the coronary bed, then you try to select the optimum stent size. How do you select the optimum stent diameter? The stent diameter should be as per the lumen size. You look here, this is the lumen area. So if it is lumen size, you upsize by 0.25 mm. If it is elastic membrane, that external elastic membrane, it should be downsized by 0.25 mm. Then post-stent assessment, once you do the deploy, whether you do IVC, IVUS or OCT, the left main area should be more than 8 millimeters, and non-left main area should be more than 4.5 millimeters of the stent lumen area. Then only we can say you have done a successful angioplasty. Then other things like malposition, tissue abrasion, injection can be done. Now let us look at the trials and studies. Previously in 2018, the king of the coronary image was IVUS. So the ultimate trial proved that IVUS was the best, and it was used extensively in all PCI. But only very recently, in 2020 or 21, we have a OCT which came into picture, where we have a study known as Renovate Complex PCI, where they were done, where OCT was used in 25% and 75% IVUS, and they did head-to-head comparison. They found that the OCT was non-inferior to the trial. But there was one study, that Illuminate trial, which showed that when OCT was compared to angiogram, mapped PCI, that OCT, though it produced a good result, but did not transform into a clinical outcome, good clinical outcome of 2 years. But this was riddled with a lot of pitfalls. because the OCT trial, most of the cases were very complex, but angiogram-related drugs were transferred to CABG. So this was then countered by October trial, where they did a OCT-guided or angiographic-guided PCI, where they convincingly proved that the OCT is associated with better outcomes after 2 years than the angiographic-guided PCI. So now OCT, there's no doubt that OCT plays a very great role, crucial role in the management of complex PCI. Now the question arises, which is better, OCT or IVUS when you do head-to-head comparison? For that, we have to look at Octivus trial, which has come out in 2023, which shows that when they did a head-to-head comparison, there were 2,000 patients which were equally divided, OCT guided PCI, 1,000 and 1,000, and they looked at the rates were similar, and the indices for the contrast-induced nephropathy was also less. And though the incidence of major procedure complications was lower with OCT compared to the IVUS, it was not statistically significant. In other words, the conclusion was OCT is a non-inferior to intravascular ultrasound for the guiding percutaneous intervention in with diverse coronary artery lesions. So in modern era, you can use the coronary imaging not only to benefit. So when you use contrast procedure, it's not only in CKD, it can be used in aged, fragile, unstable, diabetic, and low EFR. So that the patient outcome will be much better and with no risk morbidity and mortality. Thank you. Now we will we'll go to the next speaker, Dr. Rajiv Garak.
Yeah, we'll go to the next speaker and then questions in the last.
Okay.
So Dr. Pranav, you can.
Yes, sir. Good evening, sir. Good evening, respected faculty. Yeah. Sir, my screen is visible, sir?
Yeah.
So I'm presenting this case, which is we have done this month itself, and we had some issues. So I want to highlight this case so that I get a lot of learning tips and actually what are the problems they also like, rather than a success story, challenges during PCI. So this was a 75-year-old male patient. He was a farmer by occupation. He was a tobacco chewer, and like I am working in a Ratnagiri is a pretty rural area. So the patient was from a very remote locality in the hills. So he presented with unstable angina, and his biomarkers were negative. So he had a first time chest pain in his life, and in the last 2 days, and tropi was negative. So rest clinically nothing was significant. So this was the ECG. I mean, this is post PTCA, but it was the same ECG before angioplasty and angiography. So ECG showed left bundle branch block, and there was no ST elevation as per the Garbosa criteria or even the modified criteria. And the echo was consistent with LVUV. So this probably was a long-standing left bundle branch block, and the patient, as usual, has never seeked any medical attention, and he was asymptomatic otherwise. So did the angiogram, and it showed intermediate lesions. So both were ostial. So the LAD at the ostium again intermediate lesion, and LCX at the ostium also showed a focal. The LCX ostium, the LCX was bifurcating in 2 OMs, and it had a focal lesion. So I did profile it in different angles. So the deep LAO caudal view showed, though the LCX ostium was pretty okay, the OM which was coming out again had a tight disease. And this is the RCA, which showed mild, again a tortuous RCA and a mild disease in the mid segment. So with this and the patient being ACS, so these are the still images. So left main equivalent lesion, and the LAD is very good for a CABG, a good landing zone. Even the OMs are totally healthy and with good landing zone. So the choice was to clear the case for CABG or go with a complex bifurcation stenting. But again, there were a lot of challenges. The patient straight away. Yes. The patient and the relative denied CABG. I mean, that was totally out of their mind. So I thought of going ahead and do a intervention and take the case for a bifurcation stenting. So this is a guide shoot which shows the LMCA is short and there is plaque in the LMCA, and the LCX is short. Immediately it bifurcates in 2 AM, and LED is showing around 70% lesion. So because it was an ostial LED and this patient has ACS, so putting only on medical therapies again with a low EF and is again very high risk. Had this lesion been lower down, even optimal medical therapy trial would have been a good choice for him. So here I did a sequential dilatation. So my plan was very clear, is to do a provisional. There were a lot of decision taking into that, even considering his DAPT status, whether he'll be compliant or not. So just did the balloon dilatation. The lesion, we can see some adventitial calcium, and obviously there will be calcium at the ostium. So did a 2.5 and later on with a 3.0. So the 3.0 balloon had expanded properly. Both expansion and both orthogonal views we checked in, and the LED after pre-dilatation looked pretty much better. So thought of just do a provisional stenting and come out. Normally I keep a wire, but somehow for this case I was like skeptical. So I took a 3.5 into 32 sirolimus stent with the distal vessel of 3.5 and then deployed. So this was a gray stent from SMT. And generally I prefer this stent for bifurcation because it has an open cell design and there are only 2 connectors. So it is similar to a Ultimaster type of design. And so after the shoot, somehow, I mean, there was a lot of problem in hooking with the guide. And so just pulled back the balloon and thought of taking a good injection. But so during the manipulation, so during the guide manipulation, unfortunately, the guide came out. I mean, the wire came out and the guide was disengaged from the LMC. So this is actually very rare after almost 10 years of practice, but this happened after a very long time. So he just reviewed the case now, but this again going in retrospect. So this patient had tortures. I mean, he was an elderly patient. He was neglected. I mean, medically neglected because he never sought any attention, and his aorta was pretty dilated, huge dilated aorta, and he was undiagnosed hypertensive. He had tortuous the iliacs, and even the descending aorta had calcium, and the arch and the ascending aorta was very much dilated. So now I'm in a big mess because the stent is deployed at the 12 atmospheric pressure. It is a stent selected as per the distal size. The LMC is 4 mm, and I have the stent, and the wire has come out. So again, here again, I thought that it is a big mistake. If I would have kept 2 wires, it would have been a very good way. I mean, all these problems would have been avoided. So, so I thought of going. Then took. I hooked the LMCA. So the stent was not till the ostium. It was 4-5 mm proximal to the ostium. I mean, this was near the ostium. So with careful, I took a proper loop of the wire and I made a J loop and tried to rewire, though I don't have the fluoro saved to show. So with multiple orthogonal views, I did the rewiring. So we don't have imaging at our place, and hence after this, I just used the unprofiled balloon. So this was a 3.5 mm balloon and it was unprofiled. So I thought, let me just pass it and see whether I get any resist. So it went very smoothly. So I thought I have like done the task, and then I just dilated with the balloon. So I did the distal dilatation, I mean distal post dilatation of the stent, and then proximally, and I tried to take a stent boost. So everything looked good on the stent boost, the initial stent boost, and then after doing dilatation in the left main. So this was the aleocaudal and the epicanial injection, and it seemed good. So then again I took a proper boost keeping the balloon there, and then this is what is seen. So the wire has gone through the strut and it has deformed the first two struts, and the stent is displaced to one side. So I have created a kind of a new ostium now, and already it's a bifurcation lesion. And here is like what next to do and how to think on this. So now already this similar event had happened maybe around 2 years back. So there we converted into like the new ostium and then put another stent and completed in a 2-stent fashion. So here I took a bigger balloon, a 4O balloon, and then 4 into 8. This is 4 into 8 mm, and then went and gradually and to high pressure dilatations to adequately expand the new ostium and also to oppose the stent properly to the LMCA wall. So, and with this again, now there was an issue whether to go ahead with a dedicated 2-stent strategy, like go with a tap. I thought of putting a stent from LMCA to LED and then go ahead with the L6. But again, the L6, see, after giving a lot of vasodilatation, the NTG and even nicorandil, the L6 I thought was not critical, not very tight, and even it was a very angulated thing and a short lesion. So I again decided to stick back to the basic, is just do a provisional. So took a 4 into 12, again a sirolimus eluting stent from SMT, and deployed the stent from the ostium with good projections, and then just pulled back the same stent balloon, went at higher pressures, and then took the same 4/8 NC balloon and did optimization at 22 atmospheric pressures. So this is the So this is the final plane scene to see the stent. So we can see, it might not be clear on the zoom, but there are like 2, 3, the stent which is deformed is seen below, and then the LMCA, the ostium, and the stent from the LMCA to LED looks good. And then this is the final result. There was spasm, and there is the LMCA looks good, and I did the pot. So even at the the stent showed a proper opening at the LCX origin in the plane. This thing, there was mild plaque shift and mild the plaque shift with mild haziness at the LCX, but then I did not I did not want to do more, and then these are the different projections, the AP caudal, the RAO caudal, and this is the epicanial plane shoot, and this is a plane shoot stent boost. So here, finally, at this point, I accepted this result and put the patient for, just do a provisional stenting. Not even a provisional, just do a LMCA to LED stenting and just follow this patient. So this patient has completed almost now 3 weeks. He's doing good. And he's also started for his LV dysfunction on the various drugs for beta blocker sensing. So now this patient presented to us as ACS, and it was not that ad hoc PCI, it was angio and PCI done at different settings. So bifurcation lesions we are commonly encountering, and we are also doing all dedicated bifurcation strategy with good numbers. Because of certain financial resources, which I don't want to put up in an academic session, so I had decided a provisional strategy for this case. Also, this case looked with moderate or mild to moderate calcification on the fluoroscopy. So what I missed in this case, actually, we were 2 operators. So I was not so keen in the angiographic point when deciding this case. So I did not meticulously plan the case considering the other factors. And this happens when we are in rush or when we want to go up with other cases. And also, unfortunately, we have, but on that day, the long sheath and things had gone for the ETO stuff, and there was no long chain and stuff available in the cath lab. So dedicated two-stent strategies are preferred. And again, provisional is very good. It is all individual decision, and there are various criteria put up. But in situations, one person should always plan its cases properly, and should also have backup plans, and should also anticipate complications, and should be more prepared for every case. Though it might look very simple, but anywhere we can have problems.
Dr. Raju, your comments. Sir, unmute, sir. Unmute.
Yeah. So for a lucky escape,
Yes.
most important. But in places where we practice in India, your points are well taken. We do have financial limitations which should not be discussed here. And apart from it, your proper angiographic, understanding of the lesion should have been there, because you should have anticipated a deformation in view of calcific lesion, which probably a proper bed preparation would have saved it. So that is one point probably which would have been important. Even if you would have planned a provisional single stent strategy, your bed preparation was slightly on the underside. Probably you were in a hurry or whatever it is. But bed preparation definitely could have helped you better. One. Second, I think imaging, all said and done, we should, in an LMCA situation, go for a imaging gadgetry which will really assist us, because though LMCA to LAD is what you have optimally achieved, LCX would have been visualized properly on a either IVUS or ORCT. And in this forum, we should emphasize that point, because getting away with the case for the time being and versus long-term result, because all upcoming cardiologists should not go with the notion that Dr. Pranav has got away with the case, so we can also get away. They should, in a given situation, plan properly, and if possible, in all LMCA bifurcations, try to use imaging technology. Then third, most important is the stent struts are very thin nowadays. So when we choose a stent for a bifurcation or ostial situation, we should go for thicker struts. The SMT strut size is very low. Ultra thin struts these are. So the chances of deformity on slightly over pressure will be there on a higher side, though ultra thin struts have a longer and lesser rate of restenosis, but in an ostial situation still we should go for a thicker strut. What do you feel, Dr. Ramesh?
Yes, sir. So any more comments you have?
No, you can give.
Sir, I'll tell you, Pranav.
Yes, sir.
In my introductory talk, I told you, you have to plan your strategy, plan of action, and execute the plan of action taking into consideration all the clinical parameters. Probably your plan of action plan was not correct because you have not studied the problem. They say the solution for the problem lies in the problem itself. So you study the problem very well, you get the solution for itself. So I don't know, you are in confused state whether to go for bypass surgery or to go for complex angioplasty. If you wanted to go for bypass, CABG could have done a ballooning and sent him for because he had pain, you do a plain balloon, allow the blood to flow and send him for surgery. But if you're planning for complex bifurcation stenting, I think you should study very well. And secondly, never ever start a bifurcation stenting without putting a wire into the other breath. Whether you like it or not, whether we spend a little more time or not, 2 wires are always necessary. No, I'm not criticizing you. I'm telling you for the junior colleagues here.
Yes.
Whether you're hurry or not, the first thing and the basic thing is we should always have 2 wires, especially 2 main branches. Whether you want to do provisional stenting or you want to do bifurcation stenting, because that is the one which you add, and that is the one. Second, the choosing of and you don't know the underlying pathology because you have not used coronary imaging. Whether it was a thick this one thrombus or, fibrous tissue or a calcium. If you had used the imaging technique, you would have been in a better position. You could have used a plaque modification. I know, I can understand the constraints what you have. No, I'm telling you, when you have all those things.
Yes, sir.
And Dr. Raju Garg has rightly pointed out that left main stenting should not be done without imaging. If there's no imaging, better to send him for surgery. What do you say, Raju?
Yes, definitely.
And
At
moreover,
least a single graft will save
yeah.
5 to 10 years.
Yeah. And second, and the third thing was that you panicked while doing the procedure. And you never kept, and that stent deformation was because of the choosing of the wrong stent. And secondly, the guide hitting the struts quite frequently when you're going in, and that is known as grade 1A of stent deformation, which I'll show in my subsequent slides. There's a classification of stent deformation also. So your thing falls in that. And third thing is, I think you should have opened up the struts to the left circumflex because it's got pinched, there's a block shift. For some reason, if the patient develops pain and you have no time to save him, because that LCX is a major vessel supplying the non-ischemic area, it's a normal area. You should have opened the struts there, whether you do a stenting or not. Opening of the struts would have allowed some flow to that. That pinching may appear with you thinking that it's because of plaque shift, it could be due to spasm or thing. But if for some reason if there's a blood clot there, then it would you are in a great mess. Anyway, I should really congratulate you because you've been bold enough to come and present it on this platform. If it was someone else, they would have shown only the rosiest part of their intervention. What do you say, Raju Garg?
Yes. Learning from experience. Nightmares in cath lab is the most attended section in all the conferences. ACC, TCT, CSI, and this is where we learn a lot.
So I congratulate you and I congratulate you for boldness, and you got away with this case. And I tell my junior colleagues, just because Pranav got off with this case, you cannot get out. Every time we cannot be lucky.
No.
So you should plan your strategy. Planning is important. Yes. Without planning, don't do procedure. Especially you had time because this was troponin negative and an unstable angina, and it was not a acute coronary syndrome where you had to rush it. So you could have. And another thing is, please do not have ego. You can always consult your seniors. You send that email by WhatsApp and ask him how to go about. Find out from your seniors or colleagues. Plan it out because you're doing something for the patient's benefit. It's not for our ego. I may do a fantastic job and get away and get. No, it is something we are doing for the benefit of the patient. So there's a saying here. In our cath lab, we have got a big board. Leave out your ego and enter the cath lab. So when I have a problem, I call my junior colleague or senior colleague, ask them to have a second opinion. Sorry, Pranab, I'm not criticizing you. I'm just telling the junior colleagues what can happen. So whenever you have land up with problem, better to call your friends for help. They can have a second opinion. Just ask them how to go about, because two brains are better than one brain. They may find out some other way of getting out. And anyway, congratulations. Patient is doing fine. I think you cannot stop here. You have to do some follow-up procedure.
That's the learning for me, sir. That I need to follow this case, even do a check angio, and then
very closely. You have to follow up the case.
Actually, here the other backup plan in my mind was to open the strut, and then once we do that, I would have gone ahead and do tap stenting, put another stent. At times, these patients, they suddenly stop their DAPT. So here I just thought already I have created a double layer. So let me not put a third stent and let me just follow this patient. If he comes with a IS or a tight because of the plaque shift with a tight, he'll come with within 3 months he'll be symptomatic and he'll come back. And then
he'll go in directly for surgery.
So, I mean, this is the learning. That's why I wanted to present this month.
No, it's nice.
I don't know. That's really good. I learned a lot from you. Huh?
Okay. A lot of learning. Yes. Sir, you can present your slides.
Yeah. Can your slides are visible? No. Can I share this? Share. So is it visible?
Yes,
Hello?
sir.
Is it visible?
Yes, sir.
Yes, sir.
Yeah. You can just make it a full screen, sir, if possible.
Stent deformation. This is what the topic was. So the definition is it's an accidental mechanical distortion or shortening of the stent in the longitudinal axis following stent deployment, which you can see on the right side, which has happened here. And this is what I was alluding to. The proximal stent edge, because of the guiding catheter or guiding catheter extension, that could cause this. This is known as 1A classification. This is the compression of proximal edge that has caused the stent distortion or the deformation. And secondary devices like compression of the malopose proximal stent with the post dilatation balloon. And the distal stent edge is primarily because of IVUS catheter or OCT catheter being removed negligently. And the stent body, the secondary devices, when you have a post stent balloon without deflation, if you pull it out, it causes pseudofracture. Now you can see various stents here, and all the stents you can see that there is peak to valley connectors. These are the ones which causes to the stent deformation, and biometric flux and elements are most easily deformed. And the longitudinal stent compression. So it's a new complication when you are using the modern stent platform. So it's not one-off affair, as Dr. Chopra has shown. It could occur to anybody. So one should keep it in the back of your mind that stent deformation is a new thing which you have to deal with when you're dealing with new stents. So the latest stents that have come out like Elucir, Orisa, and Resolute Onyx, they are less prone for stent deformation because they are all slotted tubes, and the deformation does not occur. Whereas Resolute Onyx is a wire braided stent, and it's not only flexible, it is immune to stent deformation. So what I would say is we go with a new hat to the cath lab, and after some time we come out with a own hat. So this is a stent deformation in a short. Thank you. Now we'll take up the questions.
Yeah, in the chat. Already we are past 9, but anyway, 1 or 2 quick questions in the chat box if there are any.
Yes, sir. There is only one question I could see in the chat box from the audience. If you permit, I can read it for you.
Yeah, read it, please.
Yes, sir. The question is about the first of all, it's from Dr. Kapil Patwardhan. He's asking about the possible role of rivaroxaban in cancer-associated venous thromboembolism with the dose titration, so that the morbidity and mortality in patients with cancer can it be avoided with the dose of rivaroxaban, with the dose titration specifically.
Rajiv Garak?
In cancer, definitely rivaroxaban can be used, but with a word of caution, we do not have an antidote, most important. So if you want to use a NOAC, dabigatran is a better choice, and dose titration depends not on the cancer, but upon the CKD, basically, and liver function. Though all the NOACs, the relative renal and hepatic clearances vary, but in your choice, better choice would be dabigatran in a cancer patient, because if he bleeds by any chance or has a trauma or was supposed to go for a surgery, antidote should be available, which is at the moment only dabigatran is having, though internationally we are having antidote for rivaroxaban and apixaban also, but it has not yet come to India. What, Dr. Ramesh, what is your opinion?
Sir, I think we need to delineate why it is. You cannot just give it blindly just because the patient has got a cancer or venous thrombosis.
No. He had venous thrombosis. It is
what you told is I completely agree with dabigatran, because there is a lot of studies, robust studies are there with dabigatran, and you got an antidote also. And this patient has to be followed very carefully, clinically.
Very, very carefully. But with a documented VTE, we should give NOACs, definitely.
Yeah, so there is no further question. With your permission, sir, we will go for the conclusion. But
yes,
if any remark, if you would like to add, either Dr. Ramesh sir or Raju sir, as a closing remark.
Closing
I
remark.
think both the presenters should be congratulated. We had a lot of learning from both the cases, and most important is learning is throughout the life in our career, and we should keep doing these sessions and thank Emcure for their relentless grant, very scientific platform what they have provided for this type of activity. And I thank my Dr. Ramesh for coordinating and moderating the session with me, and the presenters who have done their job fantastically well. Life is learning always. And as Sir said, ego should not come in between. We have come from an era where Dr. Ramesh and me have seen POBA being done, where acetylene was being used, then we have changed to antiplatelet, then we have gone through Palmer shots where we used to cut the stent, crimp the stent on the balloon, and now a lot of technological change where we have seen so less of restenosis and so much secure all the juniors are. A whole circle life has come.
Dr. Ramesh sir.
So I feel this academic activity initiative is we are passing on the torch of learning and guiding to the younger generation. So the younger generation is leading the baton, because now they are used to this modern technology, and that modern technology should not be the ultimate. They should mix it with wisdom. When it's used with wisdom and the cutting edge technology, I think it would be a boon for the patient. And this wisdom will come from this particular academic platform where we learn from each other, the mistakes we do, and the solutions we find for the mistakes so that we do not repeat. So the wisdom along with the cutting edge technology should be the way forward for the management of coronary artery disease. Thank you very much.
Thank you very much, sir, from this Emcure Pharmaceuticals Limited. I'm very much thankful for, first of all, both the moderators, Dr. D. Ramesh sir and Dr. Rajiv Garg sir, for nicely directing, deliberating, and discussing both the case presentations. I'm thankful both the speaker for nicely bringing out the interesting and insightful case presentations. For all our delegates for watching us, Dr. Sasinthar and Dr. Shamraj. I'm last but not least the delegates who remained with us throughout this session. I'm very much thankful for all of them, and with the hope that we will be meeting in the next month with the again such insightful and interesting case scenarios. With that note, I would like to thank again and wish you good night and good time ahead. Thank you, sir.
Thank you, Dhamma. Thank you, Rajiv Garg.
Thank you, Ramesh sir, and thank you, Pranav, Sachin sir, and Ramadip.
Thank you.
Thank you, sir. Thank you very much, sir.
Sure, sure.